بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا. Dear colleagues, in the series of head and neck imaging, we will now discuss the topic of imaging of the larynx. You know, the larynx is one of the infrahyoid neck structures. I will discuss the infrahyoid neck separately. Then also I will have a talk about the imaging of the suprahyoid neck as well. And in order to scan the larynx, the patient is put in the supine position with relatively hyperextended neck to make the mandible outside the field of scanning. Then we have the lateral scanogram, and we scan the area from above the hyoid bone or from the floor of the mouth until we reach the upper trachea. The sections are usually taken at 2 or 3 millimeter scan intervals, and they are usually oriented parallel to the laryngeal ventricle, which is located, as I will mention, between the false and true vocal cords. Then we do not usually ask the patient to hold the breath or to stop swallowing, and these two instructions will make the patient more anxious to swallow and more anxious to have deep breath. Then don't give the patient any instructions about breathing or swallowing. And sometimes we need to inject intravenous contrast media, and after scanning we may have the 2D images, which are extremely valuable, especially the coronal ones, in evaluation of the glottic area, as I will mention. Then we use the soft tissue window for early images, and sometimes we use the bone window images if we feel that there is abnormality in the laryngeal cartilage or in the cervical spine. By MRI, we use the head and neck coil. Sometimes we use a superficial coil which is dedicated for the larynx, and this is better for giving more laryngeal details. We use the T1 and T2 weighted images in the axial plane mainly. Then we should have sagittal and coronal scans, and if there is a lesion, we may have the fat suppressed images, especially before and after injection of contrast media. Then sometimes we use the advantage of MR angiography to show the flow within some of the vessels, and this is not usually performed, but for vascular displacement or invasion we may use this MR angiogram. Then there are 3 main anatomic landmarks in the larynx, which are the hyoid bone, the thyroid cartilage, and the cricoid cartilage. And there are a lot of muscles working anterior and also inside the larynx itself. Many of these muscles you don't need to know their specific names, but when the name of the muscle is important, I will mention that, especially in the mouth floor and the tongue region. Then looking at the anatomy by CT, which is exactly similar to the anatomy by MRI, in the scans, early scans at the level of the hyoid bone, we can see the epiglottis, which is a curved structure within the air-filled laryngeal lumen, and this epiglottis is connected to the base of the tongue by this fold, which is known as the glossoepiglottic fold. And the fold separates the air anterior to the epiglottis into 2 spaces, which are known as the valleculae. Then if you follow the epiglottis lower down, and you see the fold, which is known as the airy epiglottic fold, connecting the epiglottis to the arytenoid cartilage at the base of the true vocal cord. This airy epiglottic fold will separate the air space here into a laryngeal space and an outer space, which is known as the piriform sinus or the piriform fossa. And this is the CT images, and here you can see the hyoid bone, and this is the site of the epiglottis, and here you can see what's known as the pre-epiglottic fat. Then this is the sternomastoid muscle and the carotid and jugular vessels. Then you see the left submandibular salivary gland, and this is the right one. Then lower down you can see clearly the region of the epiglottis here, and this is the thyroid cartilage. And the same by CT and by MRI, you can see this is the region of the false vocal cord. I will mention after that, but this image is just to show what's known as the strap muscles. The strap muscles are located anterior to the larynx on both sides, and this is the appearance by MRI, and this the appearance by CT. They are formed of four main muscles: the thyrohyoid, the omohyoid, the sternohyoid, and the sternothyroid. You don't need to know the names of these muscles, but just know that these muscles collectively are known as the strap muscles. Then following the airy epiglottic fold, this is the piriform sinus or piriform fossa, and you go down, this is the airy epiglottic fold, until you reach the arytenoid cartilage, and this is the cartilage at the base of the true vocal cord. This is the true vocal cord, which is pyramidal or triangular in shape, pointing anteriorly, and its base is attached to the arytenoid cartilage. Then you can see in the previous studies usually done by barium, and this is the region of the valleculae, and this is the region of the piriform sinus. Then if you have the coronal images like this by CT and by MRI, then you are able to see the true vocal cord and the false vocal cord above it, and the depression filled with air in between, and this is known as the laryngeal ventricle. In the era before CT and MRI, we used to do this laryngeal tomogram, and it was helpful, especially in evaluation of glottic pathology. And here you can see this is the true vocal cord, the laryngeal ventricle, and the false vocal cord. On the opposite side, they are involved by a laryngeal carcinoma. Then in the axial images, you can identify the true vocal cord by its attachment to the arytenoid cartilage. The true vocal cord is triangular in shape, pointing anteriorly. Its base is attached to the arytenoid cartilage. Then you go slightly upward, from this level upward, then you see a mucosal fold, which is filled by fat, and this is the site of the false vocal cord. Then first you identify the true vocal cord, then you go upward by a section or two, then you are able to see the false vocal cord, which is not a true cord, it is a mucosal fold containing fat. Then this is the true vocal cord. This is the arytenoid cartilage, the true vocal cord. You go upward, then you are able to see the false vocal cord. Then after the true vocal cord, you go inferiorly, you will see the cricoid cartilage. This is the cricoid cartilage. And then lower down, you got the tracheal rings. On either side, you can see the thyroid gland, and you remember the strap muscles along the anterior part of the larynx. The same anatomy is also shown by MRI. Here you can see the region of the epiglottis, and this is the region of the epiglottis, the pre-epiglottic fat, and these are the mouth floor muscles we'll discuss after that. And this is the sternomastoid muscle, submandibular salivary gland, and this is a slightly enlarged lymph node which is not included in the anatomy. And this is the false vocal cord by CT. The false vocal cord by MRI is a mucosal fold filled with fat. Then the true vocal cord by CT and the true vocal cord by MRI, the cartilage will show some high signal in the T1 weighted images. Then we came to the laryngeal pathology. We have two main issues here, the laryngocele and the laryngeal cancer. Then we will mention some of the other relatively uncommon lesions. Laryngocele is just an acquired dilatation of the laryngeal ventricle. The laryngeal ventricle or the laryngeal saccule, which is located in the region of the laryngeal ventricle, and this will distend by air. And the laryngoceles are usually acquired rather than congenital, and we may have three types, as I will mention, of laryngoceles, but the main cause is elevated intralaryngeal pressure, which is usually secondary to excessive cough, blowing instruments, and obstructing lesions as in laryngeal tumors. Then this is an important note. The finding of a laryngocele should prompt a search for an underlying laryngeal cancer, especially in adults. There are three types of laryngoceles. The internal one, which is totally within the laryngeal lumen. The external one, which is a bulge outside the laryngeal lumen, and a mixed one, which has a component inside the larynx and another component outside the larynx. And laryngocele can be seen by the plain X-ray, and especially in the frontal view of the cervical spine, whenever it is projected in a soft exposure, then you see an air-filled sac on the left side of the laryngeal lumen. Then the laryngocele can contain air or fluid, and sometimes whenever the laryngocele is filled by fluid, it's called a saccular cyst, but laryngocele can be filled with air and can be filled with fluid, and the attenuation of the content depend on the fluid nature and the presence of some mucus or proteinaceous fluids. Of course, you know that this is a mixed laryngocele having a part inside the larynx and another bigger part outside the larynx. In this example, we have two or bilateral laryngoceles that are mixed. This is a larger one, and you see a good component inside the laryngeal lumen reaching the region of the vallecula, and this is the epiglottis, as you know, and there is a part outside the larynx. On the right side, you can see a smaller component inside the larynx and a more sizable component outside the larynx. This is bilateral mixed laryngoceles. Also, you may have the 3D reformatted images by multi-detector CT and the 2D reformatted images by the CT as well. This is the axial image of a mixed laryngocele, internal component and external component, and this is the 2D image and the 3D image. Then the laryngocele may be infected, and at that time it will be transformed into a biolaryngocele, meaning an abscess instead of a simple laryngocele. And similar to any abscess anywhere in the body, and you have a lesion which is filled with fluid, and the margin of the lesion is uniformly thick and enhanced with contrast media. Also, the presence of laryngocele may increase the risk of laryngeal carcinoma. And as I have mentioned, whenever you diagnose laryngocele, especially by plain X-ray, you should look for the presence of an underlying laryngeal cancer. Laryngocele itself may also contain a laryngeal carcinoma. Bilateral laryngoceles are seen in about 23% of cases. Infection of a laryngocele occurs in about 10% of the cases. Laryngeal cancer associated with laryngocele is seen in about 15% of cases, and about 50% of laryngoceles detected by plain X-ray may contain cancer. Then you see a big laryngocele of mixed type, a sizable intralaryngeal component and a smaller extralaryngeal component. Then we came to the issue, which is the most important issue here, about the laryngeal carcinoma. You know that the larynx is divided into three major parts relative to the true vocal cord. The region of the true vocal cord is known as the glottic area. What above it is known as the supraglottic area. The below the lower region is known as the subglottic area. Supraglottic laryngeal carcinoma is the most common, occurring in about 60 to 70% of cases, followed by the glottic region, and the least is the subglottic area. Then you have to image laryngeal cancer for specific reasons. Number one is to detect the site and the extent of the mass, which is very important if surgery is considered. Then to show invasion of the pre-epiglottic space, the paraglottic space, subglottic extension, as well as involvement of the anterior commissure. I will show all these findings immediately, inshallah. Then CT detects bone sclerosis, especially of the cartilage, which may suggest the possibility of tumor invasion, but is not a diagnostic sign of invasion. And MRI is superior in detection of invasion of the fat planes as well as the laryngeal cartilage. Then, before the era of CT and MRI, we used to use the barium swallow or the barium studies, or sometimes we do a laryngogram to show the region of the valleculae, the piriform sinuses, and we are not able to exactly locate the site of the lesion and know its extensions by this crude method. Then after the introduction of CT in the practical imaging, then you are able to see the tumor mass, and you can exactly identify its anatomic location and size, which is very important. Then you should look for the tumor extension into the pre-epiglottic space, which is the space anterior to the epiglottis, the paraglottic space, which is the space filled with fat on either side of the larynx, then the anterior commissure, which is the junction between the two true vocal cords anteriorly, and also to assess the invasion of the cartilage. As I have mentioned, one of the best views by CT and by MRI is the coronal images to show the region of the true vocal cord, the laryngeal ventricle, and the false vocal cord. Then this is an example of a mass on the left side, and this mass is infiltrating the left side of the epiglottis. This is the epiglottis, and it also affected the epiglottic fold and extending slightly into the pre-epiglottic fat. On the coronal image, you can see the full extent of the lesion, and this is the epiglottis. You can easily appreciate that the left side is involved by the tumor mass, which is seen extending lower down, reaching almost the level of the arytenoid cartilage. And one of the valuable diagnostic benefits of the sagittal images is to look for enlargement of the lymph nodes, which are seen in the, of course, in the far away sagittal images on the left and on the right side. Then the laryngeal carcinoma is of the squamous cell type, and 90% of all laryngeal and hypopharyngeal cancers are of the squamous cell type. And lymphatic spread usually goes to the superior jugular lymph nodes. Then you see a tumor mass here, and you can appreciate the size, you can appreciate encroachment on the laryngeal lumen. Then if you look here, and this is an example, you see the epiglottis is infiltrated by a mass on the left side, extending into the pre-epiglottic space, then invading the area epiglottic fold, extending lower down, reaching the level of the subglottic area. And you are able to see if the mass is extending outside the larynx, invading the cartilage as well. Sometimes you can use the PET CT scan to assess the activity of the lesion by measuring the standard uptake value of the mass. Then you are able to differentiate between malignant lesions and the benign lesions, which are considered relatively rare or uncommon in the larynx. Then this is a mass which is affecting the right side of the epiglottis as well as the area epiglottic fold. It is seen encroaching on the paraglottic fat plane, as you can see here. And this is the sternomastoid muscle, and if you want to look for lymph nodes, and you can see, you look here underneath the sternomastoid muscle on both sides. And this is a supraglottic carcinoma infiltrating the right area epiglottic fold, extending into the pre-epiglottic space, and also has extending to the region of the thyroid cartilage, which is located here. And this is also a supraglottic carcinoma reaching the glottic area. This is the area epiglottic fold, and you got nodular thickening of the epiglottis and the left area epiglottic fold. Then lower down you get a bulky mass infiltrating the area epiglottic fold, significantly encroaching on the piriform sinus on the left side. And this is the mass. Whenever you see the arytenoid cartilage, then you know that you have reached the level of the true vocal cord. And this means that the true vocal cord is involved. Then you got glottic extension of the tumor. This glottic extension and the subglottic extension are better evaluated in the coronal images to be sure that you are reaching the true level. And this is the epiglottis, and this is the area epiglottic fold, which is infiltrated by the tumor mass, and here is the level of the arytenoid cartilage, which is reached by the tumor. Then this is a huge laryngeal carcinoma obliterating the laryngeal lumen and infiltrating the thyroid cartilage. Infiltration of the cartilage is known by extension of the tumor beyond the anatomic site of the cartilage, not by the destruction of the cartilage, because you know that the ossification or calcification of the cartilage of the larynx are not usually uniform. But if you see a mass on both sides of the cartilage, then you should know that the cartilage has been invaded. And this is a supraglottic carcinoma extending to the true vocal cord. As you can see in the coronal images, this is the epiglottis, which is diffusely thickened and swollen, involved by the tumor mass. And this is the rest of the tumor mass, which is extending lower down in the larynx below the level of the true vocal cord. And you can see in the sagittal view involvement of the epiglottis as well as the area epiglottic region, and also in the axial image you can appreciate the significant encroachment on the laryngeal lumen. Then the coronal images are valuable in evaluation of the site of the true vocal cord, the laryngeal ventricle, the false vocal cord, and to detect the extension of the tumor across the larynx, which will be reflected on the management after that. In the sagittal images, you can easily evaluate the region of the epiglottis, and also you can reach the base of the epiglottis at the level of the anterior commissure. Then the glottic carcinoma is the lesion which affects the true vocal cord. And in this example, you can see that the true vocal cord is diffusely swollen with invasion of the anterior commissure. The anterior commissure is the junction between the left and the right true vocal cord. and whenever it is normal, the thickness of the anterior commissure should not exceed few millimeters, 2 or 3 millimeters, the distance between the cartilage to the air. This is the thickness of the anterior commissure. But here, and you can see the anterior commissure is more than 1 centimeter, meaning that there is involvement of the anterior commissure. And this is also a glottic carcinoma. You see the arytenoid cartilage, you see a mass infiltrating the true vocal cord and destroying the thyroid cartilage from its anterior aspect with invasion of the anterior commissure. And this is the glottic carcinoma by endoscopy and by CT scan. This is the true vocal cord, and the cord on the right side is swollen. This is the arytenoid cartilage. You got some sclerosis of the arytenoid cartilage compared to that on the opposite side, and also some sclerosis of the adjacent part of the thyroid cartilage. As I have mentioned, the sclerosis of the cartilage may suggest that the cartilage is invaded, but they are not sure signs of cartilage invasion. And here you see a glottic carcinoma on the right side. The arytenoid cartilage is sclerosed, the vocal cord is diffusely swollen, and there is minimal involvement of the anterior commissure. And these are the images obtained by the surface coil specific for the larynx. Then you get more high resolution images, and here you can appreciate that there is involvement of the true vocal cord by a soft tissue mass, and this arrow points to that there may be some invasion outside the thyroid cartilage, but the signal intensity of the cartilage both in the T1 and T2 weighted image, it looks normal. And this is the glottic cancer with the extension outside the larynx by MRI. On the left side there is a mass infiltrating the true vocal cord with extralaryngeal extension, as you can see here. And subglottic carcinoma is the least common type of laryngeal carcinomas. It occurs below the level of the true vocal cord. Then you see a mass at the level of the cricoid cartilage. The mass has destroyed the right half of the cricoid cartilage, bulging into the laryngeal lumen, extending outside the larynx, invading the adjacent thyroid lobe. Invasion of the cricoid cartilage, and this will mean that there should be the surgery should be in the form of total laryngectomy. Then subglottic carcinoma, this is an example of a mass here. This is the cricoid cartilage. You can see the right side of the cartilage is sclerosed, and you see a mass outside the confinement of the cartilage. The superior section will show a mass in the region of the true vocal cord, and this mass has destroyed the thyroid cartilage with extension outside the confinement of the cartilage. Then sclerosis of the arytenoid cartilage, as you can see here, as well as the cricoid cartilage, as you can see here. These are not signs of invasion, but here this is the definite sign of invasion. You see a tumor mass on both sides of the heterogeneously calcified cartilage. This is also another example of a subglottic carcinoma on the left side involving the anterior part of the subglottic area, and this is the cricoid cartilage, which is normal. Then there is an extensive type of laryngeal cancer which is known as the transglottic carcinoma, starting from the supraglottic area, passing by the glottic region, ending by the supraglottic area. And this is an extensive type which is known as the transglottic laryngeal cancer. Transglottic laryngeal cancer has a component in the supraglottic area invading the glottic region. This is a sclerosis of the arytenoid cartilage, and it has also a component in the subglottic area with invasion and the destruction of the cricoid cartilage. Then you should have an idea about this appearance, which is usually seen especially after irradiation of the larynx for laryngeal cancer. Post-irradiation sequelae are in the form of significant edema of the epiglottis, significant edema of the glottic area, and you got some shrinkage and strong enhancement of the submandibular salivary glands. Then the diffusion weighted images, although they look somewhat of bad quality, but they are very important in assessment of the larynx, especially after surgery or after irradiation. Then if you look here and you see that there is a mass in the larynx which is pointed to by the arrow, this mass, this is enhancing by CT, and this is the appearance in the MRI T2 weighted image and the MRI T1 post contrast. Then in the diffusion weighted images, you can see that the mass is almost of similar diffusion appearance compared to the rest of the surrounding tissues, denoting that this is not a tumor. The tumor will show restricted diffusion, and there is no diffusion restriction here, indicating that this is just post-therapeutic sequelae. Then we came to some of the tumors and masses that can be seen in the larynx, but they are not as common as the laryngeal cancer. One of these is the hemangioma of the larynx, and the hemangioma can be seen in adults and also in children. Hemangioma is a strongly enhancing lesion, and it has a very bright signal on MRI T2 weighted image. And sometimes you can see philippuli in the cavernous type of the hemangioma, and hemangioma represents about 2 to 5% of all laryngeal tumors. And this is an MRI axial T2 and coronal T2 of the infiltrating lesion of very bright signal in the T2 weighted image, representing a laryngeal hemangioma. Well, laryngeal polyps are also seen in singers and in many who are talking a lot like me, and you can see a polyp here in the true vocal cord on the right side. These are benign hyperplastic polyps. Because of the presence of a lot of cartilage in the larynx, you may got chondroma and chondrosarcoma. And these lesions are usually or more commonly affecting the cricoid cartilage, following the thyroid cartilage, and less commonly the arytenoid cartilage, as you can see in this particular case, with a lesion infiltrating the region of the cricoid cartilage with matrix calcification, and this was proved to be a low-grade chondrosarcoma of the left arytenoid cartilage. And also here you see the tumor in the coronal images, and you got the matrix calcification, which is characteristic of chondromatous tumors. And this is also a chondrosarcoma infiltrating the thyroid cartilage. You got a mass with malignant features with matrix calcification, then you may suspect the possibility of chondrosarcoma. And actually, many times you are not able to differentiate between chondroma and chondrosarcoma unless you can see the aggressive infiltration of the tumor or metastatic lesions. Then you think of chondrosarcoma. This is the chondrosarcoma of the cricoid cartilage, and you can see there is an extensive mass. It also infiltrates the thyroid cartilage with matrix calcification, diagnostic of chondrosarcoma. Then lipoma is rare in the larynx and is commonly seen in the supraglottic area. It's just a mass which is filled with fat. And you see here a laryngeal lipoma on the left side. Lipoma, for the sure diagnosis, you should see a mass of pure fat density or pure fat MR signal intensity. But if you see soft tissues within the fat, you are in doubt about the possibility of liposarcoma. Laryngeal lymphoma is also one of the tumors that can occur in the larynx, and the presence of multiple lesions is strongly suggestive of lymphoma rather than carcinoma, as you know. I mean, if you see multiple masses in the larynx, one on the left side, on the right side, and another mass on the right side, on the left, on the opposite side, then you think of laryngeal lymphoma. And this tumor is usually seen in the supraglottic area. It has no specific imaging finding to differentiate it from the laryngeal carcinoma. But as I have mentioned, the presence of multiple lesions may suggest the possibility. If you see an example like this, the diagnosis will be laryngeal cancer, but if the lesion is biopsied, it may prove to be a lymphoma. Then you see here, this is a huge mass infiltrating the hypopharynx and also involving the thyroid lobe, and this mass was proved to be a large cell lymphoma, and this is the follow-up examination after chemotherapy. Multiple laryngeal masses is usually suggestive of lymphoma or metastasis. If the patient is known to have a primary malignancy, you can diagnose metastasis to the larynx. But if there is a no known primary malignancy, then you may suspect the possibility of non-Hodgkin lymphoma. And this is also an example of non-Hodgkin lymphoma infiltrating the laryngeal area. Two big masses on either side of the larynx, and this is not a usual feature of laryngeal cancer. Then metastatic invasion of the larynx is commonly occurring by the nearby malignancies like the hypopharyngeal cancer and thyroid carcinoma. And this is anaplastic thyroid cancer with a very big mass in the left thyroid lobe that has invaded the laryngeal lumen, destroyed the thyroid cartilage as well. This is a common occurrence in the clinical practice to see a malignant tumor, especially in the hypopharynx or in the thyroid, to invade the larynx. And this is the hypopharyngeal carcinoma infiltrating the left piriform sinus, and this is the metastatic lymph node deep to the sternomastoid muscle. These are also lymph nodes metastatic. Then hematogenous metastasis may come to the larynx from known primaries like melanoma, renal cell carcinoma, breast cancer, and the bronchogenic carcinoma. Most of these lesions are located in the supraglottic area, and there are no specific imaging criteria. But the presence of a known primary may suggest the possibility that what you are looking at is a metastatic deposit to the larynx. Alhamdulillah Rabbil Alameen. Thank you very much.